Good evening, everybody. Welcome to this webinar tonight on treatment for enlarged prostate. My name is Jan. I'm the clinical nurse specialist here at Benenden, and Mr. Steve Garnett, consultant urologist, is our expert presenter for tonight. This presentation will be followed by a question and answer session. And if you'd like to ask a question during or after the presentation, you can do so by using the question and answer icon, which you'll find at the bottom of your screen. And this can be done with or without leaving your name. And please note that this session is being recorded if you do provide your name. If you would like to book your consultation, we'll provide details for that at the end of the session. And I'll now hand you over to Mr. Garnett, and you'll hear from me again shortly.
Great, thank you, Jan. Let's just get this going. Okay. What we're going to talk about in this session about prostate enlargement is what causes it, what symptoms people get, what we do to diagnose it, and what treatment options there are, particularly focusing on the new robotic treatment that we've recently introduced here at Benenden Hospital, which is called Aquablation, but also touching on some of the other treatments we do, including TURP and UroLift. So I'm a urology consultant. I've been working at Benenden for 15 years or so now, and I've been doing prostate work for a long time, obviously, and I started introduced some of the new technology into this region as it became available, and including robotic surgery, and I do both prostate cancer and benign prostate work in my NHS and private practice. So what are we talking about with prostate enlargement? What we're really referring to is what's technically called benign prostate hyperplasia, or BPH. We now use the term BPE, benign prostate enlargement. This is a bit more understandable, but it's benign, which means non-cancerous enlargement of the prostate, and it's extremely common. It affects about half of men from the age of 50 onwards, and as we get older, it affects more and more of us. So by the age of 80, nearly 90% of men will be affected by this. So about 3 million men in the UK do have urinary symptoms associated with benign prostate enlargement. I think this is a useful picture because it shows, very graphically what we're talking about. So on the left of the picture, we've got what a normal prostate looks like. So the prostate is a small, normally about a walnut-sized gland, which sits underneath the bladder. And obviously the bladder holds the urine. And then when you pass urine, it comes out through the urethra, which runs through the center of the prostate. When the prostate gets enlarged, it doesn't just grow outwards, it grows inwards. And so it constricts or blocks the urethra. And by doing that, it causes the bladder to have to squeeze harder and work harder to try and get the urine out. And you end up with a reduced flow because of this blockage. And because you may struggle to empty your bladder very well, you can often leave urine behind. And that in turn means you have to go to the toilet more frequently. And because the bladder the muscle here in the bladder becomes enlarged and thickened. And when that happens, the muscle can become what we call overactive, or start squeezing when you don't want it to. So often people also get problems with feeling like they need to rush to the toilet. And that's what we call urgency. We don't exactly know why people get benign prostate enlargement. We know that it's linked to male hormone testosterone, and people only get enlargement of the prostate if they have the male hormone testosterone. Obviously, most men do. But exactly why or how that affects the prostate cells to make them enlarged, and why prostate enlarges more in some people than others, we don't really understand. But it is, as I said, a very common thing as we get older. So we talked a little bit about this already, but as the prostate enlarges and blocks the urethra, the symptoms typically are difficulty getting started to have a pee, going more often, reduced flow, having to get up more at night, feeling you haven't emptied your bladder, and that can lead on to more severe symptoms like problems with urine infections if you're not emptying your bladder. And as I mentioned, also this feeling of urgency of having to rush to the toilet. And it's more severe cases or situations if you're really not emptying your bladder very well, you can get problems with stones forming in the bladder, and that again can lead to urine infections. So what's the sort of diagnostic pathway? What happens? Well, usually most people will try and see their GP. I know it's not always easy, but see your doctor first, and there'll be some basic tests done in the GP practice, and you may be started on treatment by the GP, and that may be all you need. But if you end up being referred on by your doctor to a urology department, like here at Benenden, then you would come up and we would want to test your urinary flow rate, which is something we do by getting you to pee into a machine essentially that measures how well you're passing water. And that gives us a good idea of the degree of blockage from the prostate. So we'll do that. We'll check to see if there's any blood or infection in the urine. We want to check your prostate size, and you may well need to have a camera examination of the prostate and bladder, although not everyone needs that. And that's an endoscopic examination, which is called a cystoscopy. If your symptoms are not bad, if they're quite mild, you may not need any specific treatment. You may be able to manage it a bit by adjusting what you drink and when and that type of thing. And often people can just be reassured to know there isn't anything more worrying going on. But if you've got more severe symptoms, then you may need to think about starting medications, and the different types of medications, two broad groups: medications to shrink the prostate down in size, and medication to open up the prostate and allow you to pee with a slightly better flow. If the medication is not suitable for you, or if it's not working well enough, or if you get side effects from the medication, which a lot of men do, then you may need to consider intervention or procedures on the prostate. And three main ones, certainly that we offer here at Benenden Hospital, would be Aquablation, TURP, and the Urolift. There are other procedures such as laser procedures, but they're actually fairly similar, I would say, to the TURP. So let's talk a little bit about aquablation, which, as I said before, is a fairly new treatment, certainly not very widely available in the UK at this time. It has been widely adopted in the United States, but it's quite new here. It's approved by NICE and recognised as a valuable and good treatment for prostate enlargement. And it's the only treatment that's what we call a robotic procedure. So this involves setting up the equipment and mapping and scanning your prostate, and then deciding exactly what we want the ablation limits to be, and then we actually get a robot to do the ablation with the surgeon standing there, with me standing there. This uses high velocity or high pressure water jets, so there's no cutting and no heat involved, and because of this there's fewer side effects, and the high pressure water ablates or destroys the prostate according to the limits that we've mapped out. By doing this, it relieves the pressure on the urethra and allows you to pee with a better flow. We do this under general anaesthesia because it's really important that we don't have any movement once we've started the procedure. But as I say, there's no cutting and no heating involved. This is just a quick shot of some of the equipment, and it is quite sort of it involves a lot of computerized technology to map your prostate. So it does involve using an ultrasound probe to scan your prostate and then accurately measure the limits of how much prostate we want to ablate, which does make it extremely accurate real-time procedure, which allows us to be a bit more precise than some of the other treatments. So as I say, we're accurately targeting what we want to remove in terms of prostate tissue. It's a combination of a robotic machine that holds the aquablation arm and real-time live ultrasound scanning that gives us a very detailed view of the whole prostate rather than just the inside. And it's an integrated system set up so that the ultrasound and the aquablation robotic probe talk to each other with an interface and a computer-generated program. It takes about an hour to do, and usually it's a one-night stay in hospital. You would need a catheter in for that one night. It says spinal or general, but we would usually do that under a general anaesthetic. This just has a little video to show you in a bit more detail exactly what's going on. So what you can see before I start the video here is this is the robotically controlled aquablation arm or treatment. And right at the end here, this is the water jet that is fired out under high pressure. And this is the prostate tissue that we want to ablate or remove. So it's been mapped out. These green dots are the mapping that we've done to describe how much prostate we want to remove. And you can see the very outer bit of the prostate is left behind. And this area here, which is where the ejaculatory ducts come out into the prostate, is preserved. In this little tile here, what you can see is the ultrasound image that we use to generate this map and decide how much we want to remove. So the ultrasound, this is speeded up on the video here that I'm going to run, but basically we're using an ultrasound to map the prostate, decide how much we want to remove, and then the robotic arm controls how hard the water, how fast the water jet comes out, and how far it goes down and across. So let's just run this and we can see what actually happens. So the water jet will be firing side to side under robotic control. So it's a bit like a windscreen wiper going across side to side and ablating or destroying the prostate. And by setting the depth, the robot then and computer then decide how much power is required to achieve that depth. That's just showing some water coming out of the system as we're doing the procedure. And you saw a little picture there, which was the view inside of the wiper going from side to side. And then as we get towards the end here, it slows down and there we go. Not a great view at this point, but you can see just about see the jet going from side to side. And it does one side at a time at this end bit, because this is where the ejaculatory ducts and bits of stuff that allow you to ejaculate are. And one of the benefits of this procedure is it has a much lower rate of affecting ejaculation. So what are the benefits? It doesn't usually affect sexual function, which is obviously very important. And a lot of, in fact, most prostate procedures and operations do affect ejaculation or sexual function. Because there's no cutting and heat, people do seem to recover very quickly from it. As I say, it's usually a one-night stay in hospital and the catheter in over that. And a lot of patients have been coming back and saying to me, oh, how little discomfort they had, which is always very nice to hear. No incisions or cuts. And because it's robotic, it's extremely precise. And as you can see, we're able to map out exactly how much we want to remove and how deep we're going to go. With any medical procedure, there are some risks and side effects. Obviously, there's always a small risk of urine infection with any procedure on the prostate, so you would have antibiotics at the time of the procedure. You will see some blood in the urine in most people, and it can be a little bit difficult to start peeing immediately after the procedure. And again, that's the same with any procedure on the prostate. Incomplete bladder emptying, again, is an issue because some people are having this procedure done because they can't pee at all. So we can't guarantee that you'll get back to normal function straight away. Usually these side effects are mild and settle down in a couple of weeks. So I would say it's best for men with moderate to severe urinary symptoms. If you've got very mild symptoms, you probably don't need it. But we would need to do an assessment to determine if it's going to be the right thing for you. And there are always various options. One of the nice things about aquablation is it's suitable for most people. Some of the other treatments can be limited by prostate size or shape, but the aquablation is pretty widely suitable for most people. So we just talk a little bit about other treatments. So what has been the most commonly performed procedure for prostate enlargement for many years now and has been around for a long time is the TURP procedure, or transurethral resection of prostate. What this involves is putting a camera instrument down the urethra into the prostate, and through that there is what's called a resectoscope, or a little electrical loop at the end, which is able to cut through the prostate using a combination of electricity and heat that allows us to take little chips away from the prostate and essentially core out the prostate from the inside. It's a very well-established and good treatment, and many thousands of men have this done every year and have very good outcomes from it. It's certainly very successful at improving your urinary symptoms. It does have drawbacks in that it's very likely to affect ejaculation, and a small number of men have problems with erections afterwards. However, it is, as I say, very commonly performed and very reliable in terms of improving your urinary symptoms. I'll just go back for a second. Yeah, so the TURP can be done under a spinal or a general anaesthetic. It's not done under local anaesthetic. Most patients here at Benenden would have a 2-night stay in hospital and have a catheter in for those 2 nights afterwards. You tend to have some blood in the urine, and that can go on usually for a couple of weeks, but sometimes a little bit longer. And all the bits of prostate that are removed will be sent off to be looked at under the microscope to see if there's any sign of prostate cancer, and that's a routine thing. And I would say that TURP remains the most widely performed operation for prostate enlargement, certainly in the UK. I think there are some advantages to aquablation, but the TURP, if you're not so concerned about sexual function, is a very good treatment. And I'm also going to talk a little bit about the Urolift. The Urolift is a smaller procedure. It's probably the most minimally invasive treatment that we can offer. And I think rather than comparing it directly with aquablation or TURP, it's probably best to think of it as a kind of a step up from tablets, or a replacement for people who find tablets causing them severe side effects or problems. But it doesn't give quite as pronounced an improvement in flow and urinary symptoms as a TURP or aquablation does. But what it involves is putting small implants into the prostate that pull the prostate open. Because there's no cutting or removal of prostate tissue, it's a fairly quick procedure. It usually takes only about 15 minutes to do, and it's usually done as a day case, and most people do not need a catheter. But I would say it doesn't cause as significant improvement in urinary symptoms as the other procedures. And it's like most things in life, you have to weigh up the pros and the cons. And if you've got quite bad symptoms, you probably need a slightly bigger procedure than the Urolift. But if your symptoms are annoying but not too severe, then the Urolift may well be a good option for you. It says local anaesthetic there, but we generally don't do it under a short general anaesthetic because patients do find it a bit uncomfortable under local anaesthetic. We've got a little video here just to show what the Urolift involves. So this is a model of the prostate, and you can see the enlarged prostate lobes on each side. And what we'll do is just run this through. So what we're going to see now is the view that we get. So that's putting the instrument into the prostate, and we fire these little implants through the prostate. So we compress the prostate, fire the clip through, it deploys on the outside of the prostate, and then it's pulled back and the prostate is tensioned in a compressed state. So we usually put about 4 of these in, depending on the size of the prostate. And you can see by doing this, it's pulling the lobes of the prostate open or pulling them apart to create a better channel through which you can pass urine. So this isn't suitable for very large prostates because the clips simply can't open it up enough. And it's also not suitable for every shape of prostate because some men have what we call a middle lobe of the prostate, which is prostate tissue between these 2 lobes. So prostate tissue sat right here in the middle. And if you've got that, then pulling the sides open clearly isn't going to do the job there. So that's what the UroLift involves. So those are the 3 main treatments I wanted to talk about. Obviously, we're very excited to be doing aquablation treatment here, which is not very widely available in the UK. I've been very pleased to see patients coming back having really good outcomes from that. I'm very pleased with the procedure that they've had, which has been nice to see. So the TURP is a long-standing treatment and will be suitable for many patients. The aquablation treatment is newer and has perhaps fewer side effects, and particularly on sexual function. And the UroLift treatment itself is a smaller procedure that can be done as a day case and doesn't actually have any real sexual drawbacks, but may not give as much improvement. Certainly doesn't give as much improvement in flow and some of your symptoms compared to the other 2 treatments, but is a quicker procedure. So I think what I'll do is I'll stop there. We're open for questions, and you can ask a question by using the icon at the bottom of the screen. So what I'll do now is just hand over to Jan to help me with the questions, and if we get some questions, then we'll run through those.
Lovely, thank you. That was a really informative presentation, Mr. Garnett. So yeah, thank you for putting your questions in. If you have any, please add them into the question and answer icon. So one question that you probably have already answered, but after the procedure, does ejaculation occur internally?
So what the question is referring to is what we technically call retrograde ejaculation. And that means that when after some prostate procedures, when you have sex, when you ejaculate, nothing comes out and the ejaculation goes backwards into the bladder. It's not dangerous. And men who have that after procedure still have an orgasm, but nothing comes out. And obviously it does feel different and you can't have children. Now, that occurs in most men who have a TURP or a laser procedure. Certainly we would say about 2/3 of men. With aquablation, it's much less common. It happens in about 10% or 1 in 10 men. That means it can happen. And I certainly couldn't guarantee to you that it can't happen, but clearly it's much rarer and much less of a problem after aquablation.
Thank you. So can an enlarged prostate return after treatment? And if so, how frequently?
Yeah, so the prostate can continue to grow. Clearly that a little bit depends on your age because it tends to grow quite slowly. If we look at the rates of retreatment after TURP, then about 1 in 10 men have needed retreatment by 10 years. And the rates with aquablation, we don't have 10-year follow-up yet, but at 5 years, it seems slightly better than TURP. So there is a chance of it growing back, but it is a slow process in most men, as I say, about 1 in 10 after 10 years.
Thank you. And does the UroLift have a permanent effect? And if not, can you have further treatment later on?
The UroLift, I mean, again, the problem with a lot of the newer treatments is I can't give you answers to long-term sort of follow-up questions because we simply don't have that because they're new. But 5 years, probably the retreatment rate for UroLift is about twice what it is for a TURP or aquablation. So that means, yes, it's probably more likely that you would need further treatment, but you can have further treatment either a repeat urolift or a TURP or aquablation, it doesn't prevent that simply because you've had a urolift.
Thank you. And if another question, I suppose, in the same line, if my prostate continues to grow, would any of these procedures need to be repeated? And I think you've
I think that's the same answer.
Yeah. What are the pros and cons of the aquablation over the HOLEP, which is the laser surgery?
Yeah, so there are different forms of laser treatment, but HOLEP is holmium laser enucleation of the prostate. And that is doing a very similar thing, which is just using a different form of energy to core out the prostate. So with the TURP, we use electrical energy to remove the prostate chip by chip, bit by bit. With a HOLEP procedure, laser is used to core out big lumps of the prostate, which are then chopped up in the bladder and then removed. So the HOLEP and the TURP have very similar side effects, particularly in terms of sexual function. So they both have high rates of retrograde ejaculation, and they can both have rates of incontinence, although that's not common, it can happen. So I would say with the aquablation, the rates of sexual side effects are significantly lower, and there are very low rates or risks of incontinence.
Thank you. And if I take blood thinners, is there a procedure that would be better for me?
It depends what you're taking blood thinners for, really, because for most common reason for taking blood thinners is a heart condition called atrial fibrillation, which is irregular heartbeat. And for that, it's generally considered safe to stop anticoagulation or blood thinners for a couple of weeks. So all of these procedures would involve you having to stop your blood thinners. So if you've stopped them, it doesn't really make a lot of difference which procedure you have. HOLEP, TURP, aquablation, urolift, you would have to stop anticoagulation for any procedure.
Mm-hmm. And with the aquablation, do you take samples which can be checked for cancer, like the
We do take a small amount of tissue to check for cancer, but it's a much less of the prostate that's sent off to be looked at, because the amount that we're actually able to send off is quite small. I would say that all of these procedures are not really, whilst we check the tissue removed for cancer, we're not doing them because we think there's cancer there. And to diagnose cancer is a different approach, usually involving prostate biopsies rather than these type of procedures.
And with regards to recovery from the aquablation, is a recovery time quicker than a TURP with regard to exercise and getting back to normal activities?
Yes, I think that the recovery time is a little bit quicker. I think with both procedures, the first couple of weeks, you're going to be taking it fairly easy and not doing an awful lot and trying to avoid heavy lifting. But people do seem to feel back to normal and more comfortable a bit quickly. I think after a lot of prostate procedures, people do have some sort of stinging and burning, a bit of discomfort, and that can go on for at least the first few weeks, and it seems to be less with the aquablation.
And the next question, if I had surgery done, an aquablation done now at age 50, do you think it would need to be repeated again at age 70? That's probably a difficult one because not always.
Well, as I've said, any prostate procedure may need to be repeated in the future, because if you've needed an operation on your prostate at the age of 50, you've clearly got sort of quite early enlargement of your prostate, and it's likely that your prostate will continue to enlarge. So I would say whatever procedure you have, unfortunately, there is a chance of you needing something again in the future.
Yeah. And a question, if you do have prostate cancer, can it be treated with aquablation?
So aquablation is not a treatment for cancer. Okay, if you have urinary symptoms because of prostate enlargement and you've got prostate cancer, then you can have the aquablation treatment to treat your symptoms, but it's not a treatment for the cancer. So you would still need other treatments for the cancer.
Thank you. And a patient here says they had a TURP about 10 years ago, but they now feel that they're getting more urinary urgency and urinary problems. Would aquablation or TURP be best for me again?
Well, on the face of that, or without more information, but on the face of that, either treatment would be suitable for you. And you may not feel that the benefits of aquablation are particularly useful if you've already had a TURP, but both treatments would be suitable for you. And it sounds like you probably do need some treatment with the way you're describing things.
Yeah. And where does the removed tissue go with the aquablation? I suppose it's just
so a lot of the tissue that's ablated just goes into the waste, but some larger bits are removed and sent off to be looked at.
Thank you very much. Are there any other questions further down, Ollie? Or... Sorry, we're just reviewing the questions. A question, somebody's just saying, what does rectal discomfort mean with aquablation? Did you mention?
I mean, the only I'm not sure. So when we do the procedure, we do put an ultrasound probe into the back passage. I think that's the only thing I would think that the rectal discomfort refers to. So most people don't really find that, a problem. I mean, that's done for prostate cancer diagnosis with people awake, and it's usually not pleasant, but it's not painful.
Yeah. Thank you. And another question about could it be repeated? And I think we've answered that one already.
Yeah, both TURP and aquablation could be repeated.
With any of these treatments, is there an ongoing risk of incontinence?
So with any treatment to the prostate, there is a potential risk of incontinence. The risks are very low, in fact, and I know people worry about it an awful lot, but even with a TURP, it is pretty uncommon. So TURP rates of incontinence are generally quoted as around 1 to 2%, but that's 1 to 2 men in 100 having the procedure, and that does tend to be people who actually have prostate cancer, which affects the anatomy. And with aquablation, it's generally less than 1%, so very, very, very uncommon.
Good, perfect. And obviously here at Benenden, or if you're having any of these procedures, your post-op follow-up is done with us as a specialist nurses. So obviously we'll cover things like pelvic floor exercises and help you with all of that. Thank you very much. Could you just move to the last slide for me, Mr. Garnett? Lovely, thank you very much. I'm sorry if we didn't answer all of your questions today. There have been a couple of questions specifically around the procedure. So obviously the private patient advisors will be able to give you more information about that. So as a thank you for joining our presentation tonight, we're offering you a 50% reduction on your initial consultation. You will get a call back from your dedicated private patient advisor, and you will receive the recording of this webinar tomorrow. And this will also help you stay up to date with any upcoming news. If you would like to book a consultation or discuss this further, please contact the private patient team on the number that is now on your screen. They are here tonight until 8 o'clock. Otherwise, they're available Monday to Friday between 8 and 6 p.m. And again, if they have any queries, they can always check those out with Mr. Garnett and myself. We would be grateful if you could complete the survey when this session closes to help us improve our future events. The next webinar from Benenden will be on ENT treatments, and you can sign up for this on our website, sorry. On behalf of Mr. Garnett today and the expert team here at Benenden, I'd like to say thank you for joining us today. We hope you found it informative, and we look forward to hearing from you soon. Thank you very much.
Thank you.